was built to last. When the webs are weaving, I could change the past. With all I achieve.
Hello everyone, welcome back to another episode of starting ABIM using GPT-4o. This is going to be the gastroenterology episode. We're going to be going over 3 AI generated high-yield gastroenterology episodes that are created based on the internal medicine educational objectives. Basically, you will see how the AI is going to create this question and how it will analyze the answers for you based on the basically certain instructions that I've been giving and perfecting over the time that I've been working with it. This is going to help you build your own questions, and the notes will be accessible in the Patreon, so you can use the notes and then ask your own GPTs to create more questions based on the notes, so that way you will not miss any of the questions on the boards. So let's go ahead and get started. This is going to be a 68-year-old man with metastatic prostate cancer and chronic pain. He is on long-term opioid therapy. He presents with severe constipation despite increasing fluid and fiber intake, physical activity, and daily use of senadocusate. He denies nausea, vomiting, or abdominal distension. A recent abdominal x-ray shows no evidence of obstruction. Which of the following is the most appropriate next step in the management? So go ahead and pause the video right here and pick your answer. Then we're going to go ahead and go through each of them. All right. So this is going to be the initiation of the methyl naltrexone, right? So the pathophysiology of this patient is the opioid-induced constipation, which occurs due to the mu opioid receptor activation in the gut, leading to decreased motility and increased fluid absorption. The standard laxatives, such as the stimulants like senna and osmotic agents like polyethylene glycol, may not be always sufficient. Methyl naltrexone is a peripherally acting opioid antagonist that does not cross the blood-brain barrier, meaning it will relieve the constipation without reversing the opioid analgesia or triggering withdrawal. The question had some options here, so let's look at the key clues. They were telling about the patient who had chronic opioid use, and there was some refractory constipation despite the standard laxative that they were on, and the x-ray did not show any signs of obstruction. So that should have led you to methyl naltrexone. So increasing the senadocusate dose, the patient's already on this regimen, it's not going to really help. Bulk forming laxatives like Asylum, so this is like fiber, these require increased water intake and may worsen opioid-induced constipation. The diphenoxylate atropine, this is a antidiarrheal which would worsen constipation. And in the opioid dose reduction, while reducing may help, it is not always feasible for cancer patients on palliative care. Like if this patient is dealing with a lot of pain, you don't want to reverse the effects of their opioids. And then the algorithm that you kind of have to have in mind: if you have someone in mild constipation, encourage fluid fiber activity. Moderate, you can add a stimulant and osmotic laxatives. And then if you have a severe or refractory kind of constipation, then consider methyl naltrexone for opioid-induced constipation. Signs of obstruction, stop it, because methyl naltrexone is contraindicated in signs of obstruction. Always remember that. They may say, again, question may be another question. If I ask this GPT-4o to create another question, it could basically tackle a case where it will present one that the x-ray shows obstruction, and then you're not able to order methyl naltrexone. So opioid use plus constipation, not responding to laxatives, think about the methyl naltrexone. Severe pain patients like palliative care plus constipation, do not stop their opioids, treat the constipation. The latest guidelines are there. The first lines are always lifestyle and stimulant osmotic laxatives. Refractory cases for opioid-induced methyl naltrexone, and just have caution in patients with suspected bowel perf or obstruction when using methyl naltrexone. All right, so this is a very high yield question generated by AI, and so let's go ahead and move on to the next question. All right. So this is a 60-year-old man. He is presented with a 2-month history of postprandial fullness, early satiety, and epigastric pain. He has no history of weight loss, dysphagia, gastrointestinal bleeding, or iron deficiency anemia. He takes ibuprofen for knee pain occasionally. His vitals are stable. Physical exam is unremarkable. Which of the following is the most appropriate next step in the management of this patient? So basically, has 2-month history of kind of epigastric pain, and there's no alarm symptoms, and he does take ibuprofen. So what are you gonna do for him? Um, so the first one says empiric PPIs. The second one is H. pylori testing and treatment if positive. Upper GI endoscopy, discontinue the ibuprofen and observe, and then a barium swallow. So go ahead and pause the video right here, pick your answer, and we're gonna go through each. All right. So, there's a patient with dyspepsia. Dyspepsia is characterized by epigastric discomfort, postprandial fullness, early satiety, and burning pain. The most common cause would be a functional kind of dyspepsia, but serious conditions like gastric cancer or peptic ulcer disease must be ruled out, especially in high-risk patients. Remember on boards, patients with ages greater than 60, greater than or equal to 60, with new onset dyspepsia have an increased risk of malignancy and require endoscopic evaluation. So, just when you see that, the magic number here would be the age of 60. And so when you see that, you think about upper endoscopy. There's no alarming features though, but the age alone here would be a very important risk factor. Empiric PPI therapy would be an option if the patient was younger without any alarm symptoms. But in this case, with that age, we want to do the endoscopy. H. pylori testing and treatment if positive. This would be, again, for patients less than 60 years old without alarm symptoms. But this patient needs that endoscopy. Discontinuing ibuprofen observe. Well, while the NSAID-related dyspepsia is possible, as an older adults, again, we still need to rule out. And the barium swallow, not used for dyspepsia, but maybe used to, for example, for esophageal disorders. If somebody has strictures, achalasia, Zenker's diverticulum, you know what to look for. But again, this is very important for boards to realize when the age is greater than 60, what you need to do with a new onset dyspepsia and age less than 60 with alarm symptoms. We get an endoscopy, no alarm symptoms. You can do the H. pylori testing, and if positive, you can treat it. If negative, you can use a PPI trial. The pattern recognition always involves that age, and we just talked about that there. The latest guidelines always get the upper endoscopy for a new onset dyspepsia in age greater than 60. And yeah, so that's basically it. Very, very, very high yield question. If you didn't know the age and this issue, the educational objective, then the question would confuse you into, oh, well, maybe we should just do PPI, maybe we should do that and this. So yeah, I think it's a pretty good question that really hones in on this specific educational objective on dyspepsia. All right, so let's move on to the next question. So this is a 55-year-old woman. She presents with chronic constipation. It's been several years, so chronic. She has bowel movements only every 4 to 5 days, often requiring her to strain. She denies weight loss, blood in the stool, or recent changes in bowel habits. She eats a low-fiber diet and takes amlodipine for hypertension. A colonic transit study shows prolonged transit time. Which of the following is the most appropriate initial treatment? So go ahead and pause the video right here, pick your answer, and then we're going to go through each of the options together. All right. So the answer is going to be the bulk forming laxative. So let's talk about it. This patient has slow transit constipation. It is a subtype of the chronic constipation that is caused by basically reduced colonic motility, leading to an infrequent hard stools. The risk factor is, the aging, the low fiber diet, and the medications such as opioids, anticholinergics, calcium channel blockers, sedentary lifestyle. These can always do it. The first line treatment though is the lifestyle modification, which means you include fiber, hydration, exercise, and maybe give them some bulk forming laxatives like xylem or methylcellulose to increase the stool bulk and frequency. And the key clues in this question is the fact that this is a chronic constipation and not acute, and there's no alarm features. And the giveaway here for slow transit constipation is the prolonged colonic transit time on the test. So colonoscopy would be wrong because there's no alarm symptoms, no needed. This is chronic. Bulk forming laxatives are the first line for chronic constipation, especially in slow transit. So that would be the right answer. And the protein glycol, this is as osmotic laxative. It's only used for severe or refractory kind of constipation. We don't use it for slow transit. And this prucalopride or 5-HT4 agonist, it's reserved for refractory cases as well when they don't respond to the first line therapy. Discontinuing the amlodipine. So amlodipine may be contributing to this, but you would need to first of all kind of look into why they were taking it, if is it still indicated, and if they don't respond to the primary treatment, yes. Chronic constipation. So no alarm symptoms, lifestyle changes, bulk forming laxatives. Alarm symptoms, of course, get your colonoscopy. Add osmotic laxatives, polyethylene glycol lactulose for the refractory cases, and consider maybe even prokinetic agents such as the prucalopride or lubiprostone if they're severe. And then suspected medication-induced constipation. So evaluate necessity of the drug. Can you take those drugs off? We talked about the amlodipine. We talked about I think I had anticholinergics and even opioids. So we can consider those, but you need to see what the indication is for that medication. Pattern recognition for fast answering. Chronic constipation, no alarm symptoms. Fiber bulk forming, slow transit constipation, confirmed by study, first line, given silent fiber based approach. And if the refractory to fiber, then the next step is osmotic laxatives. All right, so they gave you the guidelines, the latest American guidelines, lifestyle modification, bulk forming, osmotic, and then prokinetics would be the option. So if you enjoyed this episode, I really appreciate a comment, a like, a subscribe, and you can basically have access to the notes on my Patreon channel. The link is in my video, and also in the channel trailer and the description for your use. We'll continue to use GPT in the future episodes. Then we're gonna start to change it up and use other engines and AI tools to create and generate questions and answers. That way, we will see which one does a better job and be able to compare and contrast. So I'll see you on the next one.